Chapter 5, Assessment, Nursing Diagnosis, and Planning. We're going to identify the purpose of assessment, discuss the three basic methods used to gather a patient database, differentiate objective data and subjective data, identify sources of data for the formulation of a patient database, and collect assessment data for a patient and document it. So, although assessment is an RN function rather than an LPN function, according to most state nurse practice acts, LPNs assist the RN in gathering of data. An LPN is often asked to assist with this task and participate in carrying out the plan by continuing to collect the data. In a functional assessment, the data is collected in a structured format that helps identify patient strengths and weaknesses within the context of essential human functions. In a focused assessment, data is collected only for areas with obvious problems, deviations, alterations, leading to a quick implementation of care. This approach is useful when a patient is in acute distress. During the interview, it's important that patients be made to feel relaxed so that they are open and honest and relaying personal information. In the opening, the patient should be notified of the purpose of gathering the data as well as how the information will be safeguarded. In closing, the patient should be allowed to ask questions, especially about the interview process. The chart review gives a quick overview or profile of the patient. Ideally, the chart review should be done before the first contact with a new patient. However, that's not always achievable in a busy healthcare setting. Specific information about activities of daily living or ADLs, mobility, elimination patterns, nutritional intake are just some examples of some of the stuff that we are going to ask them about. And here you see a list of additional information that you may find in the chart review. The physical examination is performed by the RN. Parts of the exam may be delegated to the LPN. A complete head-to-toe physical examination can take an experienced person 30 minutes to an hour to complete. An abbreviated examination is often done by the nurse on admission. An overall quick assessment can be done. It's usually followed up with a more in-depth assessment as time permits. Sometimes a walking shift report is made in which each patient is quickly observed prior to exchanging information among nurses. Just to remind you guys, so anything that you find, if you have an admission, that you need to immediately report to the RN or your charge nurse is going to be difficulty breathing potentially, shortness of breath, no breathing or apnea, pallor, cyanosis, and agitation. The patient can be awake without being alert. However, the patient cannot be alert without being awake. Level of consciousness follows a continuum from fully awake to drowsy, lethargic, stuporous, and finally unarousable or comatose. Orientation looks at the content of the responses. It indicates patient awareness of date, place, and self. If all are intact, it is indicated as oriented times 3. Depending on the clinical setting, the LPN may be asked to obtain the vital signs. However, this may be delegated to our nursing assistant. Vital signs that are abnormal should be reported to the RN or charge nurse because additional actions may be required. Vital signs should be completed and assessed as often as ordered by the physician or requested by the RN based on the changing status of the patient. Vital signs are checked at least once per shift for the hospitalized patients and perhaps once per day in less acute settings. It's like rehab. In the acute care setting, heart, lungs, and abdomen should be auscultated at least once during a shift. If a patient reports or the notation indicates no bowel movement for more than 3 days, what might you do? That's going to be a reportable finding, right? That's extremely abnormal. Something is definitely wrong with our patient. Same thing with, we already talked about difficulty breathing, or if you're hearing something weird when you're listening to the heart or the lungs. For the patient who cannot follow commands well, spontaneous movements in bed can be observed and noted in the chart. If the patient guards one side or doesn't move an extremity effectively, some impairment might be implied. Diminished pulses or cyanotic coloration, especially distal, so furthest away from the head and the heart, are important findings. A decreased temperature or edema, those are all very important, that are peripheral circulation abnormalities. So you need to pay attention if you find any of those abnormalities. The location of all tubes and equipment attached to the patient should be noted. The anatomic insertion site should be noted for all chest tubes, drainage tubes. Anything else you find as far as IVs, wound suction devices, if the patient has sequential compression devices or SCDs, anything like that, you need to make a note of that they have them on, that they have a tube, where is it? A functional assessment often is supplemental to the history and physical examination. A functional assessment yields information about the patient's level of independence and ability to perform ADLs. It also helps identify problems that can be addressed by nursing. The family is assessed regarding attitude and ability to help with the care of a patient, their ability to provide emotional support for the patient, and their ability to cope with the situation. We're also going to provide them teaching that will, on discharge, that they'll need to be a part of. Question number 1. As part of an assessment, the nurse asks for information from the patient. This information is a subjective indication of illness perceived by the patient and is called a or an number 1, assessment, number 2, symptom, number 3, sign, or number 4, observation. So the answer is number 2. Symptoms are subjective indications of illness that are perceived by the patient. Question number 2. All of the following components can be found on the patient's chart except number 1, a face sheet, 2, a physician's order, 3, patient's history and physical, or 4, a patient's nurse assignment. It is number 4. The patient's nurse assignment is part of the unit staffing information, and it's posted in the unit. It's not part of a patient's chart. Question 3. Linda knows as part of her nursing assignment that she is to review and update the nursing care plan on her patients. Number 1, hourly. Number 2, every shift. 3, every 24 hours. Or 4, weekly. The nursing care plan is reviewed and updated every 24 hours. Necessary changes can be made anytime. Usually the nursing care plans are evaluated over night shift. So if you guys start off on night shift, just know that the RNs usually update those during night shift. All right, section 2 of chapter 5. Correlate patients' problems with nursing diagnosis from the accepted North American Nursing Diagnosis Association International. So this is called the NANDA-I. In clinical practice, we'll analyze the data collected to determine patient needs, identify appropriate nursing diagnosis from the NANDA list for each assigned patient, and prioritize the nursing diagnosis. Once the information has been gathered, the database is analyzed for cues that indicate deviations from the norm. Cues are pieces of data or information that influence decisions. The medical diagnosis is never included in the construction of the nursing diagnosis. So there's a medical diagnosis, there's a nursing diagnosis. The RN indicates the nursing diagnosis, but the LPN is expected to contribute to the plan of care once the diagnoses have been identified. So what is the difference between subjective data and objective data? Subjective data is what the patient tells you. It's what the patient says. It's what the patient tells you. Objective data is what you collect by examining the patient, what you see yourself, what data you collect. It's strictly facts. Nursing diagnoses differ from medical diagnoses in that the nursing diagnosis defines the patient's response to the illness, whereas the medical diagnosis labels the illness. Priorities of care are set so that the nurse will first attend to the most important interventions for the high priority problems for each patient. Order can be guided by the hierarchy of needs adapted by Maslow, according to the patient's belief regarding the level of importance of each problem and by what is most life-threatening or problematic for the patient. The same process is used to analyze data, identify problems and safety concerns, and to choose nursing diagnoses appropriate for the new resident. Question number 4. Which of the following sets of assessment data is most likely to be present with the nursing diagnosis risk for infection? Number 1, fever, dysuria, change in urine concentration and urinary urgency. 2, abdominal pain, sore mouth, hyperactive bowel sounds, and leukopenia. Number 3, fatigue, electrocardiographic changes, dependent edema, and activity intolerance. Or 4, abdominal incision, decreased hemoglobin, and indwelling catheter present. It is going to be number 4. Number 4, assessment data used to make a nursing diagnosis include medical history, physical examination, lab analysis, and data from the nursing history and assessment. A risk for nursing diagnosis describes human responses that may develop in a vulnerable person. Options 1 and 2 contain data that indicate an actual infection, while option 3 has no data to indicate an increased risk for infection. Third section of chapter 5, we're going to identify appropriate outcome criteria for selecting selected nursing diagnoses, plan goals for each patient, and write outcome criteria for the chosen nursing diagnoses. And in our clinical practice, we'll write specific goal and outcome statements, plan appropriate nursing interventions to assist the patient in attaining the goal's expected outcomes. So the The patient or significant others should be included in the goal setting process. Nursing interventions should give specific steps to be executed or actions to be taken in order for the outcome to be achieved. For example, how could you be more specific about an intervention such as maintaining skin integrity? Well, we can reposition the patient every 2 hours. We can use padding to protect bony prominences. We can move the patient in and out of bed with a sideboard. Just an example. Although the LPN may be quite knowledgeable on the patient's status, the RN is ultimately responsible for the appropriateness of the plan of care. Many healthcare facilities now use computerized programs to assist in constructing the nursing care plan. The nurse chooses the appropriate nursing diagnoses and then is presented with computer screens from which to choose the expected outcomes and the nursing interventions. As the patient's status changes, the care plan is updated to reflect the current status. Question 5. A nurse has established expected outcomes for an assigned patient. The nurse carries out this important activity for the purpose of, number 1, evaluating the occurrence of complications, 2, measuring the quality of care, 3, measuring the effectiveness of nursing interventions, or 4, stopping care when outcomes are met. Answer is number 3. The purpose of establishing expected outcomes are to direct nursing interventions, maintain continuity of nursing care, and measure the effectiveness of nursing interventions.